senior consultant from head and neck surgery. Today we will be discussing the last topic related to thyroid cancers. We are going to discuss regarding systemic therapy and radiotherapy in thyroid cancers. We have Dr. Nirdhum Shikha to present the topic. Today we have Dr. Manisha Singh ma'am with us. She is the head of the Department of Medical Oncology at Mahavir Cancer Sansthan. She has been a torchbearer in the institute since years, and we are very happy to have you here, ma'am. Welcome, ma'am. And today we have our session moderator, Dr. Avinash Upadhyay. He is an eminent medical oncologist from Mahavir Cancer Sansthan. He is yet to join, but I just had a dialogue with him and he told to start the session. He will be joining soon. So we will continue with the session, ma'am.
Sure, go ahead, Vinay.
Yes,
I've just come back from hospital. We had an interview ongoing.
Yes, ma'am. Yes,
doctor's interview. So please go ahead. Go ahead.
Yes, ma'am. Thank you, ma'am.
Thank you, ma'am. Thyroid cancer is because of the aberrant signaling of PI3K, which is phosphatidyl inositol 3 kinase 3 kinase, then AKT, mammalian target of rapamycin, and mitogen activated protein kinase. Now, how does this thyroid cancer occur? We will deal about the molecular pathogenesis of thyroid cancer. Now, there is receptor tyrosine kinase, which is seen in thyroid cancer patients, which activates the PI3K and MAPK pathway. This is the first pathway. Now, second, this receptor tyrosine kinase also gets induced at the cell membrane and activates PI3K, AKT, and mTOR pathway. After this gets activated, the PI3K phosphorylates and forms AKT. Now, this AKT has got two roles. Outside the nucleus, it upregulates the oncogene and also activates the mTOR pathway. The other way it acts is it enters the nucleus, as you can see in the diagram, that the AKT in the nucleus also causes tumorigenesis. So it has got two ways of mechanism of causing tumorigenesis. One, outside the nucleus, where it upregulates the oncogenes and activates the mTOR pathway. And second, it enters the nucleus and causes the tumorigenesis. This is one way. Now, this was through the receptor tyrosine kinase acting at the cell level. Now, at the gene level, it also mutates several genes, which includes MEK, ERK, RAS, and BRAF. Now, if there is mutation in these genes, it can also cause, it is also a cause of thyroid cancer. Out of which, if you see ERK, the ERK enters the nucleus and causes tumorigenesis. This was one way of the pathogenesis of thyroid cancer. Now, the other way is the PI3K and MAPK activates the HIF, that is a transcription factor, hypoxia-induced factor 1 alpha. Now, what this does is, in the tumor which has got hypoxia, the tumoral hypoxia, it causes the overexpression of vascular endothelial growth factor, which causes angiogenesis. This is one way. Now, this also targets the MET receptor, which causes angiogenesis, cellular motility, invasion, and metastasis. Now, what are the mutations seen in different thyroid cancers? First is papillary thyroid cancer. Papillary thyroid cancer. So in this, the point mutation is seen in BRAF, 40% of patients about, and in RAS, seen in about 38% of patients. Another mutation which is seen is rearrangement of RET proto-oncogene, which is seen in about 10 to 20% of patients. Third is a mutation in anaplastic lymphoma kinase, that is ALK. And the fourth is neurotropic tropomyosin receptor kinase, which is seen in about 1 to 2% of cases. Why it is important for us? In the further slides, we will be seeing the drugs which will be targeting these oncogenes. The next is follicular thyroid cancer. Most of the point mutations which is seen in follicular thyroid cancer is RAS, and the other one is rearrangement of PAX8 genes. Also, mutations in PI3K pathway is seen, such as PTEN deletion or mutation and PIK3CA, but in lesser frequency. Coming to the next part is medullary thyroid cancer. Most of the genetic alteration which is seen is RET activating point mutations. Another one is RAS. There are about 32 genes mutations which is seen with RAS. Mainly what we see in the medullary thyroid cancer is two gene mutation, that is HRAS and KRAS mutation, which is seen in about 17% of cases. Next is anaplastic and poorly differentiated thyroid cancer, that is T53 and TERT promoter mutations. And the bad thing about this is usually associated with greater aggressiveness. Now, what are the indications of systemic therapy in thyroid cancer? In a patient who has already received 600 millicurie of dose of RAI, and they are not going to get benefited further with RAI treatment, they become an indication for systemic therapy if they have a progressive disease. Number one. Number two, if a patient has got a disease progression and if it is threatening and if it requires intervention, but if we do any kind of intervention, it can lead to morbidity or mortality. So in those cases, systemic therapy is useful. For example, in case if a patient has got lung or lymph node lesion, which can cause airway obstruction or hemorrhage in those patients. Third, if a patient is symptomatic and cannot be managed with a local directed therapy, for example, if a patient has got multiple lung metastasis and which is causing breathlessness to the patient. Fourth is when there is a diffuse disease progression rather than a focal progression. So I'll be dealing under these headings for the therapeutic options, which is in all the types of thyroid cancer. First is RAI refractory TTCs, ATCs, that is anaplastic thyroid cancer, and medullary thyroid cancer. So it is subdivided into cytotoxic chemotherapeutic agents. Second is targeted, which is again divided into multikinase inhibitor and specific inhibitors, which includes BRAF inhibitor or combination of BRAF and MEK inhibitors, mTOR inhibitors, and selective RET inhibitors. The next topic will be the immunotherapy checkpoint inhibitors, and the last one will be tumor agnostic options, including pembrolizumab. Coming to the first part, that is the cytotoxic chemotherapeutic agents. Now, this has got a very limited role in the treatment of cancer because of its disappointing efficacy. So, in patients who have got differentiated thyroid cancer, chemotherapy is not generally recommended because of two main reasons, that is the poor response rate and short duration of response. Other than that is the toxic effect of chemotherapy. Coming to the drug which has been approved by FDA, the first drug was doxorubicin in the year 1974. Doxorubicin has shown a partial response of about 30 to 45% in differentiated thyroid cancer. The next is persistent or recurrent medullary thyroid cancer. When we combine for this, the combination chemotherapy that is based on dacarbazine and doxorubicin has been tried. However, the results are limited with a response rate of about 10 to 15%, and that is partial response. Now, the anaplastic thyroid cancers. This is the type of thyroid cancer where the chemotherapy benefits to the patient in addition to surgery and radiation, and has shown longer median survival rates. So the group of drugs that is used is doxorubicin, which is the anthracycline type of chemotherapy, taxanes, which is paclitaxel, docetaxel, platin, cisplatin, or carboplatin. They have got activity with a response rate which ranges from 15 to 25%. Now coming to the tyrosine kinase inhibitors. The first is motesanib diphosphate. This was the first international clinical trial for thyroid cancer, which was started in the year 2005. There were two studies separately done for refractory differentiated thyroid cancer, where 93 patients were included. The median progression-free survival noted was about 40 weeks. The other study that was for the metastatic progressive or symptomatic medullary thyroid cancer, where 91 patients were included in the study, the median progression-free survival was 48 weeks. Now, when we see the adverse effect, it had diarrhea, fatigue, hypothyroidism, hypertension, and anorexia. However, there was no phase 3 clinical trial in this, and this is not FDA-approved drug. Coming to the second multikinase inhibitor, that is sorafenib. Now, this inhibits all three vascular endothelial growth factor receptor, that is VEGFR 1, 2, and 3. Next, RET also. So this is a multikinase which acts at VEGFR also, RET also, RAF also, but it is not selective BRAF inhibitor, and platelet-derived growth factor receptor beta. The mechanism of action is by inhibiting the cancer cell growth through both the anti-proliferative and anti-angiogenic mechanism. This has gone through a phase 3 trial, which was the decision trial, where sorafenib was used against the placebo in about 417 patients, and most of the patients were metastatic differentiated thyroid cancer. There was a benefit in progression-free survival of about 6 months, and it was statistically significant. Adverse effect most commonly seen was hand-foot syndrome, diarrhea, fatigue, rash, and hypertension. This is the drug which was FDA approved for RAI refractory differentiated thyroid cancer. Coming to the lenvatinib, this is another drug which is used for RAI refractory differentiated thyroid cancer and is FDA approved. It acts by inhibiting the VEGFR, FGFR, that is fibroblast growth factor, PDGFR, KIT, and RET. It has gone phase 3 trial, which was the SELECT trial, where it was used in a dose of 24 milligram once daily in a cycle of D1 to D28. 392 patients were included in the study, and mostly were metastatic differentiated thyroid cancer. The progression-free survival noted was about 15 months, which was statistically significant. The most common adverse events that was observed were hypertension, diarrhea, fatigue, weight loss, and proteinuria. Coming to vandatinib. So vandatinib is a RET kinase inhibitor. So this is one drug which can be used in medullary thyroid cancer. It is an oral inhibitor of RET, that is rearranged urine transfection kinase. It also acts on vascular endothelial growth factor receptor and EGFR. So it has action. It is a multikinase which can be used in medullary thyroid cancer patients. So there was a phase 3 Zeta trial that was done, where 331 patients with locally advanced unresectable metastatic medullary thyroid cancer patients were included. When we saw the objective response rate in this study, it was statistically significant, and the response rate was about 13 to 45%. Now, the other thing which was seen was there was improvement in calcitonin and CEA levels also, which was statistically significant. Now, these group of patients, in out of 331, 52% of the patient has sporadic MTC, that was sporadic medullary thyroid cancer, in which a subgroup of patient had M918T mutation positive. And when we saw the analysis and the response rate, it was found to be better in patients who were M918T mutation positive. The most common adverse effect which was observed was diarrhea, rash, nausea, hypertension, and fatigue. Now, this is one drug which is approved by FDA in the year 2011 for patients with unresectable or metastatic MTC. Now, this is also a very important drug, that is cabozantinib. This is a multikinase inhibitor of MET, VEGFR, RET, KIT, AXL, FLT3, and TIE2. So when the action of it is seen, it has got properties against the cancers which are derived from epithelial and mesenchymal origins like renal cell carcinoma and thyroid cancer. As you see, it acts on both the mechanism, that is RET, and also the mechanism which causes the differentiated thyroid cancer. So this is one drug which is actually approved by FDA for both, which is the unresectable metastatic medullary thyroid cancer and also RAI refractory DTCs. The first phase 3 exam trial, which was for MTC, the progression-free survival was 11.2 months versus 4 months in the placebo patients. Now, Cosmic 311 trial was also a phase 3 trial where they evaluated the efficacy and safety of cabozantinib in RA refractory DTCs who had either progressed during or after VEGFR targeted therapy, that was sorafenib or lenvatinib. So in these patients, what they saw, there was 78% reduction in the risk of disease progression or death in the cabozantinib arm compared to the placebo, and it was found to be statistically significant. Seeing the adverse effects, it has diarrhea, weight loss, hand-foot syndrome, hypertension, fatigue, anorexia, is the one. Now the dose varies between the DTC and the MTC. In the DTC, the dose is 60 mg in the trial which was used, and for the MTC, it is 140 mg. Now, the next one, that is a completely inhibitor of VEGFR 1, 2, 3, that is exitinib, not FDA approved. There was a phase 2 trial which was done for a locally advanced MTC, RAI, refractory DTC, which was metastatic and or unresectable. The objective response rate which was seen was 35% with the median progression-free survival of about 16.1 months, and the median overall survival was 27.2 months. The adverse events that was noted was diarrhea, fatigue, weight loss, and hypertension. Now, this is another drug, that is sunitinib, again not FDA approved. It is one of the oral TKIs which inhibits VEGFR, PDGFR, c-KIT, FMS-related tyrosine kinase 3, and RET. It acts by inhibiting the pathway leading to the apoptosis of cancer cells, and it reduces the tumor vascularization, which ultimately results to the tumor shrinkage. It is used in RCC, renal cell carcinoma, GIST patients, pancreatic neuroendocrine tumors. Sunitinib has shown activity in thyroid cancer, both MTC and DTC. However, there is no phase 3 trial. There was a phase 2 trial where the maximum objective response rate was seen in MTC, which was about 38.5%. In DTC, it was 22%, and no objective response was noted in anaplastic thyroid cancer. The adverse events were fatigue, hand-foot syndrome, and weight loss. Coming to the next drug, that is pazopanib. This acts by inhibiting all three VEGFRs, platelet-derived growth factor alpha and beta, and c-KIT. It has activity against DTC and MTC with a response rate of 49% in DTC and 14.3% in MTC, with adverse effects of hypertension, fatigue, abnormal liver function test. And it is still not FDA approved. Now, this is very important, where we will be talking about specific inhibitors of BRAF or MEK inhibitors. So, BRAF mutation is not only seen in thyroid cancer, it is also seen in other cancers like hairy cell leukemia or melanoma or colorectal cancer, etc. But in thyroid cancer, it occurs in about 30 to 80% of the human thyroid cancer, and the most frequent mutation that is observed in thyroid cancer is V600E mutation. How does it affect us? If the patient has got BRAF mutation, the clinical behavior is aggressive, higher chances of recurrences, and poor survival rates. It also leads to the alteration in the iodine metabolism in the follicular cells, and because of which there is poor response or refractoriness to the RAI therapy. The drugs which fall in this category are vemurafenib, dabrafenib, and encorafenib. There are evidences which suggest that if BRAF inhibitors are used, it helps us in restoring the iodine responsiveness of the thyroid cancer, and probably through the reactivation of genes involved in iodine metabolism, which can help us in helping the patient to be responsive to the RAI therapy. However, if we use these BRAF patients as a single agent because of resistant to it after some time, because of activation of other downstream pathways, it is better to use it in combination with another drug which is along with the MEK inhibitors. Now, the example of this MEK inhibitor is trematinib. They have suggested that when we combine these two drugs, the results are more effective. Now, there are few studies which are done for this, where dabrafenib and trematinib both have been used. The first is a phase 2 clinical trial, which was BRF 117019 trial, where they had included the anaplastic thyroid carcinoma, BRAF mutant patients. The total number of patients were 16 and were followed up for 47 months. The objective response rate was about 69%. Now, there was another study which was done by Wang et al., where he used it as NACT drug, where dabrafenib was used in a dose of 150 mg twice daily, and trematinib was used in a dose of 2 milligram daily. So, and it was used for, again, same unresectable mutated ATC patients. The total number of patients were in the study was 6, and they were followed up for 1 year. The overall survival was 83%. A similar study was conducted by MD Anderson Cancer Center, where they again used it as NACT, and it was a study which was carried on for about 20 years, with a total number of patients 20 who were BRAF mutation positive. The overall survival noted at the end of 1 year was 94%. Another study used vemurafenib, that was Bros MS et al. They also used in BRAF mutated patients, but those were papillary thyroid cancer. The total number of patients was 26. The partial response was 38.5, and stable disease was seen in 57.5% patients. Coming to another group of inhibitors, that is mammalian target of rapamycin, mTOR inhibitors. Now, PI3K, AKT-mTOR pathway is a downstream of RAS, and activation of these patients mostly occurs in the advanced thyroid cancer. The drugs which fall in this category are everolimus and temsirolimus. There was a phase 2 trial which was done, and by Hanna et al., the median progression-free survival in the differentiated thyroid cancer was about 12.9 months. In medullary thyroid cancer, it was 13.1 months. When it was used as a single agent, there was no improvement. So it was combined with a multikinase inhibitor, which was sorafenib. The partial response which was noted with 55%, which was again when it was compared to sorafenib alone, which was much higher. There was another study which was done by Schneider at TC et al. It was again a phase 2 trial where he had used everolimus in medullary thyroid cancer, and stable disease was noted in 5 out of 7 patients. However, this drug is not FDA approved. The adverse effects that is seen in this is mucositis, anorexia, pancytopenia, hyperglycemia, liver function test abnormalities, and rarely pneumonitis. Now, this is again very important, the selective RET inhibitors. So, This is selpercatinib. This is one drug which is used in ret mutated medullary thyroid cancer and ret fusion positive thyroid cancer. The disadvantage of this drug is it is used in patients who are more than 12 years of age, cannot be used in pediatric patients. So there was a study which was done, that was a Libretto 001 trial, where selpercatinib was used daily with a dose of 160 milligram in patients with ret mutant medullary thyroid cancer. What they found was the objective response rate was about 69% in among 55 patients who had taken TKIs previously, including cabozantinib and vandetanib. The adverse effects of this drug is fatigue, diarrhea, constipation, dry mouth, nausea, and dyspnea. This is a FDA approved drug. Now, another drug which is a selective RET inhibitor is bralcetinib. This is second potent RET inhibitor with its activity in RET fusion positive medullary thyroid cancer. There was an ARROW trial, which was phase 1, phase 2 trial. What they observed was the objective response rate in fusion positive thyroid cancer patient was 91%, and in patient who had when it was used in medullary thyroid cancer, in naive patient the overall objective response rate was 74%, and in patients who were treated with different therapeutic drugs, the objective response rate was 60%. When we saw the side effects, constipation, elevated liver enzymes, hypertension, fatigue, and peripheral edema were the side effects. This is also a FDA approved drug for MTC. Now there are multiple clinical trials which are coming, phase 3 trials, which are trying to combining the selective RET inhibitors along with multikinase inhibitor, for example, selpercatinib and pralsetinib along with cabozantinib and vandetanib. However, the results are awaited. So this is another selective inhibitor, that is neurotropic tropomyosin receptor kinase inhibitors. Now there is existence of gene fusions in NTRK, ALK, and ROS1 in subgroup patients of papillary thyroid cancer, poorly differentiated thyroid cancer, and anaplastic thyroid cancer. Altogether, the disease becomes more aggressive. So there are two drugs which is FDA approved, that is larotrectinib, which is a selective pan anti-RK inhibitor. It was studied in cancer patients that harbored anti-RK fusion positive DTC and ATC patients. In a study where TRK fusion positive iodine refractory DTC patient of a total number of 28 patients, the objective response rate was about 75%. Now the dose for this is 100 mg for adults, and for pediatric patient it is 100 mg per meter square. The another drug which is entrectinib. It is a potent inhibitor of anti-RK like larotrectinib, and along with it, it also targets ROS1 and ALK. Now, third drug which is a crizotinib. This is a ALK inhibitor, and there was only one case reported in literature where a patient of ATC who failed with the standard therapy, this drug was given and he was successfully treated. There is no phase 1, phase 2, phase 3 trials of this drug so far. Now, immunotherapy. It is gaining momentum in the advanced thyroid cancer, including the immune checkpoint blockade, like inhibition of programmed cell death protein PD-1, cytotoxic T lymphocyte associated protein 4. There are multiple drugs which are used along with and in combination with and those phase of trials, the results are awaited. The most used drug right now is pembrolizumab, which is approved by FDA for use in patients with thyroid cancer of any histology who show high microsatellite instability. Other than that, nivolumab is one drug, and spartilimumab is another drug which has been used in anaplastic thyroid cancer patients. Now, the whole thing what I have mentioned so far, this has been summarized beautifully in this picture, where all the drugs acting on the particular receptor and how it where it is inhibiting has been shown in this diagram. Coming to individually management of each thyroid cancer. This is the first one, that is RAI refractory advanced metastatic differentiated thyroid cancer. Now, if there is a progressive disease with multiple lesion, our first choice would be lenvatinib, sorafenib, and other options like pralsetinib or selpercatinib can be given. Now, in patients who have taken lenvatinib and sorafenib and they are resistant to it, cabozantinib is a good drug of choice. In patients who have got multiple lesions and are symptomatic, in them again lenvatinib and sorafenib are the first drug choice. Other options include pralsetinib, selpercatinib, entrectinib, etc. Now, in cases of medullary thyroid cancer, so the first drug of choice in cases of patients who have got progressive or symptomatic disease, multiple lesions, cabozantinib and vandatinib are the drug of choice. Other options include pralsetinib and selpercatinib. Now, in anaplastic thyroid cancer, we have BRAF testing. So if the patient is BRAF mutated, we will use the combination of dabrafenib and trametinib, which is a BRAF plus MEK inhibitors together. Now, if the patient has got wild type BRAF, so in that cases, targeted therapy, immunotherapy, and clinical trials are of use. Now, coming to the NCCN guideline for ATC, this is for patient who got operated and require adjuvant treatment. The recommended regimens include paclitaxel at 50 mg per meter square, carboplatin with a AUC of 2 weekly given, docetaxel, doxorubicin with a dose of 20 milligram per meter square each weekly, paclitaxel alone 30 to 60 milligram per meter square weekly, docetaxel 20 milligram per meter square weekly. Other systemic drugs that is again used is BRAF mutation positive patient, or dabrafenib, trametinib can be used, or anti-RK, larotrectinib or entrectinib can be used, or RET positive patient, pralsetinib or selpercatinib can be used. Other regimens include paclitaxel, doxorubicin, paclitaxel carboplatin combination, or docetaxel doxorubicin combination given at an interval of 3 to 4 weeks or weekly. The another drugs which can be used is doxorubicin along with cisplatin given 3 weekly, pembrolizumab along with lenvatinib can be given at a dose of 200 mg IV every 3 weekly or 400 mg IV every 6 weekly. If lenvatinib is added, 20 to 24 mg of lenvatinib per oral daily. Nivolumab can also be used where in a dose of 240 mg IV 2 weekly or 480 mg IV 4 weekly. Coming to the radiation therapy, in differentiated medullary or poorly differentiated, the non-anaplastic thyroid cancer, adjuvant treatment, adjuvant RT for high-risk disease after R1 resection. I'm saying again R1 resection. If there is a microscopic disease which is at the thyroid bed with involved resected lymph node regions. The dose is 60 to 66 grays. With every fraction, we give about 1.8 to 2 gray. In for elective nodal regions, 50 to 56 gray, with 1.6 to 2 gray per fraction. The second is in cases of R2 resection or inoperable patients. So there is a gross disease there. The dose increases. The dose is 66 to 70 gray in 1.8 to 2 gray per fraction. Microscopic disease, 60 to 66 gray, and per fraction 1.8 to 2 gray is given. Elective nodal regions, again it is same, 50 to 56 gray in 1.6 to 2 gray per fraction. Now, if there is a bony or soft tissue metastasis, oligometastasis with a good performance scale, 45 to 60 gray can be given in per fraction 1.8 to 2 gray, or stereotactic body radiation can be given. In cases if patient has got wide metastasis with a poor performance scale limiting their life expectancy, we can consider a single fraction of 8 gray, or 20 gray in 5 fractions, 30 gray in 10 fractions with 3 gray per fraction. Now, for anaplastic thyroid cancer, we give adjuvant RT after R0 or R1 resection for microscopic 60 to 66 gray, 1.2 gray twice daily fraction, that is hyperfractionation, or 1.8 to 2 gray daily fractionation. Elective nodal regions, 45 to 54 gray in 0.8 to 1 gray twice daily fractions, or 1.6 to 1.8 gray once daily fraction. Chemoradiation can be considered on an individual basis. So in patients now with R2 resection or inoperable patients with gross disease, the dose is 66 to 70 gray with either 1.2 gray twice daily fractions or 1.8 to 2 gray daily fractions. If there is a microscopic disease or high risk region, 60 to 66 gray in 1.2 gray twice daily fractions or 1.8 to 2 gray daily fractions. Elective nodal regions, we will give 45 to 54 gray in 0.8 to 1 gray twice daily fractions, or 1.8 to 1.6 to 1.8 gray once daily fraction. Chemoradiation may be considered on an individual basis. For palliative neck RT, we can give 20 gray in 5 daily fractions, that is 4 gray per fraction, or 30 gray in 10 daily fractions, or 45 gray in 15 daily fractions. Now, for bone or soft tissue metastasis, 8 gray in 1 fraction can be given. Palliative intent, 20 gray in 5 daily fractions or 30 gray in 10 daily fractions. Now, when it is brain metastasis, if it is solitary, neurosurgical resection can be done, or stereoradiosurgery can be done. If there is multiple CNS lesion, can be considered for a whole brain radiotherapy, or stereo radiosurgery can be done. In patients, SBRT, in ATC, SBRT or SRS can be given. Stereotactic radiosurgery is usually the radiosurgery to the brain, that is, for example, using gamma knife. SBRT is usually a high conformal radiotherapy, which is given in 3 to 10 fractions. Now, to conclude this, though this topic is very big and very less time to speak in covering every aspect of it, it is a very big topic. But to conclude in short, I would say a recent understanding on the molecular basis is utmost important, as day by day there are newer advances. There is next gene sequencing that has come up, so there are a lot of treatment approaches that is changing, and the treatment approaches are day by day getting there are a lot of drugs which are coming for the advanced and recurrent diseases. Now, when it is radio iodine refractory or poorly differentiated thyroid cancers, the first choice of drug will be sorafenib and lenvatinib. For medullary metastatic thyroid cancers, it is vandatinib and cabozantinib. Cabozantinib is also approved for radioactive iodine refractory differentiated thyroid cancers, where giving sorafenib and lenvatinib has not helped, or the disease is still progressing, we can use cabozantinib. Other than that, a combination of BRAF inhibitor, dabrafenib, and MEK inhibitors is approved in patients who have got BRAF mutation and patients with unresectable locally advanced anaplastic thyroid cancer. The next is RET kinase inhibitor, that is selpercatinib, which is used against the advanced RET mutated medullary thyroid cancer or RET fusion positive thyroid cancer of any histologic type. These are my list of references. Thank you.
Thank you, Dr. Shikha. It was regarding this topic. For
So systemic therapy and radiation therapy in thyroid cancers, what I have understood over years, in radio refractory well differentiated thyroid cancers, we do require systemic therapy. Earlier we used to give lots of doxorubicin, paclitaxel, which still works in anaplastic, where the conventional TKIs do not work. And in other differentiated thyroid cancers, when they became radioiodine refractory, there comes the role of systemic therapy. We have multi-kinase inhibitors with us, like lenvatinib, sorafenib. So we do use these molecules regularly. The side effects and all, because the doses are really high, lenvatinib we use 24 milligram, where in hepatocellular carcinoma it is just 12 milligram. So lots of side effects also are seen, hand, foot syndromes, skin rashes, diarrhea, we do see, but patients are more or less able to tolerate at least 14 milligram to 20 milligram. Side effects will be seen almost in 40-50% cases. BRAF inhibitors do have a role in anaplastic thyroid cancers, but the availability of drugs is really tough over here, because dabrafenib and tramatinib both are really costly. And the way they work in thyroid cancer compared to other cancers is little different. In other cancers, they do really well, but in thyroid cancers, the outcome is not that great. Apart from this, radiation therapy, I mainly see the role in particularly in anaplastic carcinomas, where it's difficult to operate and patient is having symptoms. We do use radiation therapy. Well differentiated thyroid cancers, the invent of TKIs, they have really eased our life. And I have seen patients doing well even for years, like 1 year, 2 years, they are still in follow-up, they are doing good. Medullary thyroid cancers also, cabozantinib and all, it has revolutionized the idea of getting this angios done, at least for like RET mutations, where selpercatinib and all has come, and BRAF testing. This shall be done anti-RK. This shall be done at baseline. In most of the patient, we at least counsel them to get this done. Medullary, so particularly familial medullary thyroid cancers can be familial. So we generally tend to do the counseling part so that they shall get at least genetic testing done, particularly in medullary thyroid cancer, and NGS, so that we can derive the therapeutic benefit for them. But it difficult in our setup, but yeah, the people who are sitting in big corporate hospitals, they're getting it done. Where the patient is affordable, they're getting it done. And that's it from my side, I believe.
That's very insightful. I just wanted to ask, how do you select patients? Like one is affordability. The second is, does all patients who are refractory or anaplastic thyroid cancer, so all these patients, can they be offered, like all the patients, or in that also we do select? What are the criteria?
See, well differentiated thyroid cancers, you can offer.
I think you have to unmute.
TKIs. Well differentiated. Anaplastic, we do need to get NGS done. because this lenvatinib and sorafenib does not work well in anaplastic. There, either we need to give radiotherapy, sometimes we do give chemotherapy still, paclitaxel, doxorubicin, and in patients who are affordable, like if we are getting BRAF done and BRAF mutation comes positive, we can use the combination of dabrafenib plus tamatinib. I'll say that treating anaplastic thyroid cancer is still a challenge because BRAF does not come positive for every patient. However, differentiated thyroid cancers, you can use multi TKIs which targets multiple factors. So there it works good. So differentiated thyroid cancer is still, it's a way to go. And in all patients who are radiorefractory, we do offer this kind of therapy, particularly if the PS we do take into account, like performance status should be at least 1, 2, 3, and 4. Generally, the toxicities will be on higher side. So it is difficult to give TKIs also for a long duration.
Okay. Hello. Manisha ma'am.
Hello. Anything? So I think this session was great. Slides I have just gone through briefly. I think slides were good enough, and it was the knowledge given was great. I think in thyroid cancers we shall also focus on. I think you would have covered that, the surgery part and the radiotherapy iodine part, because that also is very, very important. And even in patients who are having bony mets, we know that the surgery followed by radioiodine therapy, they are still curable, I mean to say.
Yes, sir. Actually, we had a separate topic of RAI and surgical. So this was mainly just the systemic therapy and radiation therapy, the last part of the topic, sir. So we had covered in a segment, sir.
Okay, fine. If you have done that, that is great, because sometimes when we do enter in oncology, we think that, okay, bony met stage 4, but thyroid cancer, the staging is not like that. So I think we shall know about the surgery part, the importance of surgery and radioiodine therapy, because systemic therapy generally in thyroid cancer comes late when they become radiorefractory. Otherwise, mainly surgery and this part takes care of thyroid cancers.
Yeah, whatever the disease, if it is resectable, first we have to go for resection. That is
exactly. So that emphasis should never go. The emphasis has to be there. Like, we have to get surgery and radioiodine therapy done.
Sir, can you explain the rule in and rule out molecular study test?
Yeah, I have not gone through those studies. Like, it has been a while. But definitely, I'll connect later when I'll explain all this. In nutshell, only what I felt, what I have gone through, I told you.
Okay.
I'll go through the study separately and then I'll let you know.
Study is a concept only.
Hello.
Concept only, sir.
Dr. Avinash. There was one thing. What about in our institute? What are the protocols which you are following?
In our institute, what we are following is multikinase inhibitors we are offering for differentiated thyroid cancers. Because see, here also we are not able to get NGS done for any patient. So lenvatinib, cabozantinib I have used in patients, and they have done really good. And undifferentiated thyroid cancers, anaplastic thyroid cancers, we generally have used chemotherapy and radiation therapy only, because BRAF testing only is difficult to get that done. And even if it is done, the cost of dabrafenib and tamatinib still has to come down. So it is in lakhs. So that we have not used. But other centers do use this BRAF inhibitors.
The cost is one of the issue.
Cost is a major issue. This lenvatinib, cabozantinib, the monthly cost will be, I think, it will cost around 15 to 20,000 per month, whereas this goes up to 1.5 to 2 lakhs. So that becomes a major factor we are not using. Then anti-RK inhibitors, this is selpercatinib. These are all newer drugs which is very, very costly. And then when the cost comes down, we will be able to use in our patients.
सर आईएससी में ब्राफ देखते हैं कि आप उसमें एनजीएस टेस्टिंग ही करते हैं?
बेसिकली एनजीएस ही करते हैं उसमें. आईएचसी से we do not do BRAF.
Okay, but we read कि ब्राफ आईएससी में भी मिल जाता है. That I was not.
See, you can do BRAF testing by IHC. Problem is that IHC itself is very, very rare. so it is not available. When you do NGS, you do not miss any kind of mutation. See, BRAF also has got various type of mutation. V600E is the most common mutation,
Yes.
which we target generally by using this dabrafenib and trametinib. But there are lots of different mutation which comes in BRAF which do not respond to this dabra and tramat combination.
Okay.
So NGS is the ideal test to do, so that you can pinpoint, okay, this type of mutation is going to respond or not.
Thank
So
you.
generally we tend to keep NGS done for BRAF.
And Dr. Avinash, when do you deem the treatment to be unsuccessful or the disease is progressive? Is there any intervals where you get the scans?
Generally,
or,
3 months. Generally, 3 months we follow. Otherwise, clinically, if patient is improving, what we tend to do just to decrease the cost. If patient is clinically responding, we just tend to avoid scans. We do it at 6 months. In some patients, even 1 year, if they are continuing, they are doing well, and we know that they are not going to get the scans done, we generally just leave and we just continue the medicine. If the patient is doing good, just continue. Otherwise, routinely for 3 months, we get that scans done, and interval of 3 months, the recommendation wise.
Perfect.
Okay, Dr. Vinay, I'll connect you later. My mother is waiting actually. I have